end-stage arthritis, which require joint replacement surgery. But the most commonly we see two type of arthritis. One is osteoarthritis, second is rheumatoid arthritis. So these are the two different spectrum of the arthritis, and it makes the major bulk of the arthritis. So this, if I tell something, few words about the osteoarthritis, it's the age-related arthritis. It's mainly affecting all the joint, including carpometacarpal joint, finger joints. It can involve wrist joint. It can involve a hip joint, knee joint, spine. But the distribution is differ from the rheumatoid arthritis. In the rheumatoid and osteoarthritis, the distribution is not necessarily bilateral symmetrical. But in rheumatoid arthritis, it is a systemic disease. Not only the bone and joints get affected, but other systemic illness is a rule in this rheumatoid arthritis. So start from the ocular manifestation. It can cause keratoconjunctivitis, sicca, episcleritis, scleritis. Neurological, it can cause a cervical myelopathy. Hematological, it can cause the anemia of the chronic disease, neutropenia, splenomegaly. It can cause lung pleural effusion, pleural fibrosis. It can cause pericarditis, heart disease, myocarditis. It can cause membranous nephropathy. So it can involve all the organs of the body. So it's just by introduction, you can understand the severity of the rheumatoid arthritis as compared to the osteoarthritis, which is little benign type of things. And the treatment of rheumatoid arthritis varies, various disease modifying drug, steroid. It complex the situation. The long term, because of the deleterious effect of this drugs, can complex the situation when I take patient for the surgery, especially the joint replacement. So there is a definitely this condition is complex condition. So the patient with rheumatoid arthritis often have additional medical, anesthetic, global musculoskeletal problem that is not present in the osteoarthritis patient. It has array of the bone and soft tissue deformity which is not present in the osteoarthritis patient. This is third point is important. The patient with rheumatoid arthritis are on average 10 years younger than the as compared to the patient of the osteoarthritis. Mean the onset of the illness is approximately 10 years younger as compared to the osteoarthritis. And the another point, important point is the patient who land into the for the joint replacement is 20 years younger than the about osteoarthritis, and the bone age is about 20 years more than that as compared to osteoarthritis patient. So successful knee arthroplasty in rheumatoid arthritis depends on the pre-operative optimization of the patient general, medical, nutritional, and musculoskeletal status. As I told, because this situation is complex by the medical treatment, complex by the systemic involvement of rheumatoid arthritis. So before we plan any surgical treatment, we should look for the patient general condition, medical condition, nutritional state, because the anemia is very common. Skin condition is poor because of the chronic use of the steroid, and proper joint exposure is a rule, and ligament balancing is very important aspect. uh, in rheumatoid arthritis, the bone defects are the very common as compared to the osteoarthritis. The bone defects are the very common, so we should focus on this defect management, and ultimately the rehabilitation is a very important aspect for this managing this rheumatoid arthritis patient. So what are the bony changes present in the rheumatoid arthritis is bone erosions, osteoporosis because of the disease itself and because of the chronic use of the steroid. Patella is usually thinned out. So whenever we do replacement, we always think twice before resurfacing patella. One or both knee ultimately will be affected in almost 90% of the individual. 90% of the individual having one or both knee. About 65 to 75% of the patient, both knee are affected. So as I told you, the deformities, bony deformity defects are common in the rheumatoid arthritis because this prostaglandin, because this inflamed synovium is a factory of the prostaglandin, and this prostaglandin having deleterious effect on the bone, and it can cause the bone absorption and the cavity formation. So this is a clinical picture of one of my patients showing the defect, showing the cyst formation in the medial condyle of the femur. The risk of the infection, again, this is a very important point. Risk of the infection in rheumatoid patients is about 3 times greater than the general population because of the, again, because of the systemic disease. The patient is on the disease modifying drug, which complex the situation. Patient in the steroid, again, which complex the situation. So whenever we plan for the surgery, we should be very cautious in taking this patient, strict OT discipline, the proper use of the antibiotic. So this aspect is very important. Risk of infection is 3 times more than the general population. The majority of the patient undergoing knee replacement surgery secondary to rheumatoid arthritis are having two kinds of deformity. The basically two kinds of the deformity is present in the end stage knee of the rheumatoid. The one is ligament laxity with hyperextension and no fixed deformity, only ligament laxity. And the second kind of the deformity having the fixed flexion deformity associated with the varus or the valgus deformity, and it can be of a various severity. So this is an example of the ligament laxity with hyperextension and fixed without fixed deformity. This lady is having the hyperextension of the both the knee joint. It can cause the defect on the anterior aspect of the joint. And the another kind of the deformity which is present is the fixed flexion deformity with either varus or the valgus deformity, and it can be of various severe form. This is a clinical picture, X-ray picture of the patient having the fixed deformity. The fixed flexion deformity we can categorize into basic three classes: grade 1, grade 2, grade 3. The grade 1, if the deformity is less than 10 degree. Grade 2 is if deformity is 10 to 30 degree. Grade 3 is if it is beyond 30 degree. But sometime in my clinical practice, I saw patient which having very serious deformity. It can lead up to the almost 100 degree of the flexion deformity. So this is very profound, very severe type of the fixed flexion deformity. So this is a X-ray picture of the patient, 42 years old patient, FFD with valgus deformity. You can see how the knee look deformed, how it is fixed in the flexion. So what changes we can think of in patient of the FFD? Skin tightness, skin is fragile, the legs anterior structure, because of flexion, the anterior structure is lax. Decreased quadriceps strength because the quadriceps length is increased, so the strength is decreased. The soft tissue contracture posteriorly because the anterior structure, the convex side is loose and the concave side is always tight. This is basic rule. Convex side is loose and convex side is always tight. The posterior cruciate ligament, posterior capsule, gastrocnemius, hamstring, collateral, all get tightened in flexion deformity. I'm not, hello. Share. Move नहीं हो रहा है. I'm not able to. So what would be the goal of surgery? We just understand what is basic pathology in the rheumatoid patient. What kind of the deformity we can encounter in the rheumatoid patient. So we should precise our treatment plan. We should plan treatment very judiciously, and we fix our goal of the surgery and what kind of the benefit we can provide to our patient. So first is we correct the hyperextension with minimal bony cut. This is very key point, minimal bony cut, because knee replacement surgery says it's basically soft tissue surgery. It's not a bony surgery, it's a soft tissue surgery. So especially in the rheumatoid, avoid we should avoid our temptation to cut more and more bone to correct the deformity. So we should balance the knee rather by the soft tissue balancing. Second goal would be to correct the varus and valgus deformity, to correct the significant varus contracture, minimum approximately to the 1/3 of its severity, because it says intraoperatively we should not overcorrect the hyperflexion FFD in a rheumatoid knee. We should always leave behind 10 to 20% of the deformity on table, and later on it get corrected by the physical therapy, because in rheumatoid there is a tendency of lax tissue. And the fourth most important point is to manage the bone effects. So any latent deformity should not be corrected simply by the bony resection, rather by the tight contracted soft tissue must be released, and it provide the properly balanced knee. So if I'll see the technique, the gap balancing is the key. As I said, as I told you, the gap balancing means we should titrate our each and every step by the soft tissue tension rather than bone cut. We should be very gentle in handling the attenuated ligament, soft tissue. Soft tissue includes the posterior cruciate ligament, collateral release, posterior capsular release, hamstring release. We should remove the all impinged bone, the loose bodies, osteophytes. We should manage the bone defects. Bony cut should be minimum. Original tibial, we maintain the original tibial slope, that is a 3-degree. Adequate femoral cut, upsize up the femoral component. Again, this is a technique recently advised by Western surgeon to upsize the femoral component and the putting in implant in flexion to balance the fixed flexion deformity and to manage the avoid the mid flexion instability. So this is a clinical picture of lady having the severe fixed flexion deformity. I just showed her picture in my previous slides. So this lady is approximately 42 years old female, not able to extend her knee, having the severe fixed flexion deformity. It's her X-ray. So this goniometer showing approximately 100-degree of the fixed flexion deformity. So if the deformity is more than 60-degree, we should opt for the two-step procedure. The step one is release of hamstring. Although the release of his hamstring in literature says it's the last procedure. End of the surgery, we can think of the release of hamstring. But in my practice, if the deformity is very severe, I always start with the hamstring release to downsize the deformity. And the step two is soft tissue release plus TKR and avoid excessive femoral cut. This is very important. We should not the distal femur more than 4 millimeter. So hamstring tenotomy, traditionally, as I told you, this is the last, but I opted as a first step, two tendons, semitendinosus and biceps femoris, which is easily palpable. So this is my video. If I hope you are able to see my video. So when I apply extension force on the knee, on the posterior aspect, I can very easily palpate the two tendons with the 11 number knife. We just give out and give a nick over the tendon. So PCL plus capsular release is a very important aspect to correct the tight extension gap. The posterior capsular release and PCL sacrifice is a very important to correct these deformities. The posterior capsule plus gastrocnemius released by the curved osteotomy. I always use this double cut out of the osteotomy to reach up the posterior aspect of the femoral condyle. It's very easily I can approach without damaging the posterior structure, because the precious neurovascular structure lies just behind the medial condyle of the femur. In severe case, I do not hesitate to do the horizontal cut of the posterior capsule. As I told you, I always apply amputation to cutting extra distal femoral bone to balance the extension, because whenever there is a fixed flexion deformity, the flexion is loose. But when I put patient in the knee extension is always tight. So I always try to balance knee by releasing the posterior capsule, sacrificing the PCL rather than cutting the extra distal femur. This is clinical picture. This lady, you can see the post-operative picture. She can extend her knee very comfortably, full extension. So pitfall of the excessive distal femur resection. As I told you, I should always avoid my time to cut distal femur extra. It can cause the joint line elevation. It can change the joint force. It can affect the quadriceps mechanism. It can cause mid-flexion instability. The mid-flexion instability is a very deleterious thing. So whenever patient is trying to get up from the chair, try to climb the stair, he always will instability in his knee. So it's also alter the patellofemoral kinematics. So we should always avoid cut the excess distal femur cut. On table, the complete correction of the severe FFD in rheumatoid arthritis, as I told, is not a good job. So always leave behind some 1/3 of its deformity on table, which is later corrected by physical therapy. And again, if I always try to avoid constraint type of the processes, more the constraint, more is the chances of the implant loosening in a due course of time. So prosthetic that is highly constrained can transmit shear and rotational force to the bone cement interface, and therefore theoretically it can cause the implant loosening. So simpler the implant, more is the survivorship of the implant. So another point is, as I told you, this synovium disease, synovium can secrete prostaglandin, and it causes various kind of the bone defects. So in varus knee, in flexion deformity, bone defect is posteromedial defect is present. In the flexion deformity with varus, posteromedial defect is present. In hyperextension, as I told you, the deformity is of the bone is present anteriorly. So this is a clinical picture of the one of my patient showing the contained defect. I mean the defect is surrounded by the cortical bone, so it is contained defect, and it's not very difficult to manage this kind of the contained defect. So depend on the size of the defect. If the size is 5 to 10 millimeter, it can easily manage by the filling the cancellous bone graft, which is amply available during the surgery. My cut distal femur, cut chamfer cut box. So the ample amount of the bone is available intraoperatively. So there are several methods of the correcting the bone defect. Depends on the bone where it is, the side of the bone, defect, and the what kind of the bone defect is present, and the size of the bone defect. So even I can take the, if the defect is very large, I use bone graft. I take out the bone graft is amply available intraoperatively. So I put this graft through the K wire and fixed in the defect and take a cut. So it very well flush with the bone, and you cannot appreciate this is a bone graft. So this is bone graft, but it's difficult to appreciate this is bone graft. It look like a natty bone. The concern in FFD is gap balancing. The flexion gap is more than extension gap. Whenever there is FFD, the flexion gap is more than the extension gap. So main focus is equalizing the both extension and the flexion gap for the successful knee replacement surgery. So extension gap, this is extension gap, always equal with the flexion gap, which is taken when knee is flexed in the 90-degree. So as I told you in my previous slides, there is one more method to manage this flexion and extension gap is upsizing of the femoral component and putting in a flexion, slightly flexion. Navigation is a very important tool. I'm lucky I have this navigation machine. So navigation gives you very good precision, very good idea about the balancing the knee. So it shows before surgery, like in this particular patient, 0.5-degree valgus deformity, flexion is 31.5 degree, external rotation 2 degree. So after surgery, because of this precision, how much degree of the deformity is present, and during surgery, my computer prompt me to take proper cut of the bone so that I can manage this kind of the deformity. So after surgery in the same patient, I almost achieved the full correction. So I just show you the few examples. This first lady is, my first case was 38 years old female, hyperextension with varus deformity, neuropathy because of the rheumatoid arthritis, and this is a systemic disease. Patient having the difficulty in walking, and patient is azathioprine and on a steroid. I showed this lady in my previous slide. So she walks with a hyperextension gait, January curvatum. So for her, this walk without support was impossible. She had to take walker support for walk. So this is her pre-operative X-ray. You can see the big deformity on the medial side. Anterior, uh, there is a bone loss on the anterior side. This was her MRI. So this was my navigation picture before surgery. The varus 14.5, hyperextension 20, external rotation 7.5. The left knee having the similar kind of the deformity. So I used the assistance of the navigation, and I almost corrected her deformity. This was her intra picture. Because of the severe bone loss anteriorly, I had to use bone wedge to correct this deformity, because this kind of the big deformity cannot get corrected by the bone graft alone. This was her post-op picture. So this was post-op picture. The second case of 44 years old female, bilateral FFD, difficulty in walking since 1 year. The patient was on methotrexate and naflunomide, but it was drug defaulter. Look, without support, she had to take support of the at least 2-3%. This was her X-ray. This is post-op picture. So it was well balanced knee. The basic thing is we should focus on the balancing the knee with the help of your precision. If you have facility of the navigation is available, this is wonderful tool intraoperatively to guide me for the balancing the knee, take the proper cut. My third case was 55 years old female. She was drug defaulter, polyorticular involvement with the terminal deformity. She was unable to walk without assistance for last 3 months. Look, the extent of the deformity, her all joints got worn off, including the metatarsal, metacarpophalangeal joint, this hand joints. She was completely gone case. She was not able to stand even. So this was her intra-op picture. Look, the all joints is worn off. Look, inflamed. So this was her post-operative picture. And the lady who came to my clinic with on wheelchair, even after the replacement of the one knee, she is able to walk comfortably. Comfortably. Even I did second knee replacement. I didn't have her clinical picture now. So to conclude, TKR in rheumatoid arthritis with multiple deformities is always at high risk for heterogenic fracture because of the weaker bone. Bone is very fragile in rheumatoid patient. There are 3 times more chances of the infection. There are chances of instability because of the lack soft tissue. But with proper OT discipline, gap balancing, and soft tissue release with judicious bony cut and implant size modification, we can achieve the satisfactory result. Though demanding, the TKR in a rheumatoid patient is more rewarding in terms of the relief of the pain, mobility, and the deformity correction. In my all previous patients who are not able to walk, I made them walk from the very same day of the surgery. So this is very rewarding surgery. The computer navigation is definitely a powerful tool in getting the optimal stability and alignment. Disease modifying drug like methotrexate, hydroxychloroquine can continue same during and peri-operative and post-operative period The biological agent should stop 1 week prior till 1 week post-op, because there is a high chances of infection if we continue the biological agent. And we should start anti-osteoporotic therapy post-operatively. These are the chart showing the which drug, which disease-modifying drug should be continued. Thank you.
Thank you so much, sir. Thank you so much, sir. Your lecture was very nice and wonderful speech. Thank you so much.
So if you have any question, we can, I think we should continue with the question session right now, because I had to go for one surgery. If you permit me, I can answer your queries.
Thank you so much, sir.
Thank you.
Dr. Rajesh?
Yes, sir. Yes, sir.
Rajesh, if anyone have question, they can ask me.
Okay, okay. No, I think no questions. And thank you so much for your lecture. Your lecture is so lovely and wonderful. Thank you so much.
Thank you. And thank you. I want to add one more